Welcome to all the nursing legends in training. Now, let me ask you this. What do stiff fingers, aching knees, and sudden toe pain all have in common? They are signs of arthritis. And if you are preparing for the NCLEX, this is one topic you absolutely need to master. In today's video, we will break down the types of arthritis, the causes, the symptoms, diagnostic tools, and key nursing interventions, all explained in a clear and practical way. And here's the best part. Stay with me till the end because we will finish strong with NCLEX-style questions to review what you have learned. We post high-yield, exam-focused nursing content like this every single day, so make sure to follow us and keep coming back for your daily dose of NCLEX preparation. Let us get started. Wait a moment before we continue. This could change your entire NCLEX preparation. Our complete NCLEX review course includes 100 hours of animated lectures, 500 hours of deep dive teaching, 5,000 powerful practice questions, 500 next-generation NCLEX-style case studies, and 15 full-length exam simulations. You will also receive a full-access NCLEX ebook for 12 months. The course is now 70% off, but not for long. Tap the link in the description and get started right now. Now, let us talk about one of the most common yet often misunderstood conditions you will encounter in nursing: arthritis. Whether you are caring for elderly patients, middle-aged adults, or even children, understanding arthritis is essential for both the NCLEX and your real-world practice. Let us start from square one. What exactly is arthritis? In simple terms, arthritis means inflammation of one or more joints. Now remember, joints are places where two bones meet, like your knees, fingers, or hips. And when these areas get inflamed, that is arthritis. But here is where students often get confused. Arthritis is not just one disease. It is an umbrella term that includes over 100 different types of joint conditions. Some types are caused by wear and tear, others by your immune system going rogue, and a few by infection or crystal buildup. So as nurses, we have to be detectives, because not all arthritis looks the same. Imagine a retired athlete who spent years playing football and now struggles to bend his knees. That could be one kind of arthritis. Now, picture a young woman who wakes up every morning with stiff, swollen fingers that take over an hour to loosen up. That is a very different kind. Both have joint problems, but the cause and treatment are totally different. Now, picture this. A 68-year-old woman says, "Nurse, I cannot open my jar of peanut butter anymore because my fingers hurt too much." That is arthritis affecting her hand joints. And for her, something as simple as making a sandwich becomes a challenge. This is why nurses need to understand arthritis, not just for the NCLEX, but because it impacts quality of life every single day. All right, before we move forward, let us break down something that often shows up on the NCLEX and can easily trip students up if they are not paying close attention. Yes, we are talking about the different types of arthritis. This is where many students stumble, not because it is too hard, but because the names and symptoms can seem so similar. But I promise you, once you understand the key differences and apply them to real-life scenarios, it all becomes crystal clear. Let us dive into one of the most common NCLEX trap topics: types of arthritis. Let us dive right into osteoarthritis, also known as OA. Now this one is super important because it is the most common form of arthritis, and it is exactly what we call the wear and tear type. So let me help you visualize it. Picture your joints like shock absorbers lined with smooth cartilage that helps cushion the bones. This cartilage acts like padding, allowing smooth movement without friction. But here's the problem. Over time, especially after years of physical labor, repetitive movement, or simply aging, that cartilage begins to wear down. Think of it like the sole of a favorite old shoe. You wear it long enough, and it starts to thin out. Once that protective cushion is gone, the bones begin to grind directly against each other. And that friction causes pain, stiffness, and reduced mobility. One key clue that you are dealing with osteoarthritis: the pain usually gets worse by the end of the day, after the joints have been working hard all day long. Now, let me give you a real-life scenario to bring this home. Imagine a 70-year-old man who spent his entire career working in a factory. He was on his feet all day, lifting heavy loads, walking on hard concrete floors. Nowadays, he tells you that his knees ache after long days, but he actually feels fine when he first wakes up in the morning. That is textbook osteoarthritis, pain that builds up with use throughout the day, not pain that hits you first thing when you wake up. So always remember, when it comes to osteoarthritis, the wear and tear story is what makes it stand out. Now, let us move on to rheumatoid arthritis, or RA. This one is completely different from osteoarthritis because it is not caused by wear and tear. Instead, it is an autoimmune condition, which means the body's own immune system mistakenly starts attacking the lining of the joints, causing chronic inflammation. Rheumatoid arthritis usually begins in the smaller joints, think fingers and wrists. And here is the kicker. It is typically symmetrical. So if one hand is affected, you can expect the other to be affected too. A major clue that points toward rheumatoid arthritis is morning stiffness that lasts longer than 1 hour, much longer than what you would see in osteoarthritis. Now let me bring this to life with a clinical situation you should picture. A 35-year-old woman comes in and tells you her fingers are so stiff in the morning that she can barely brush her hair. It takes over an hour before her hands feel somewhat normal, and she also complains of feeling tired all the time and having a low-grade fever. This is a textbook presentation of rheumatoid arthritis. Symmetrical joint involvement, prolonged morning stiffness, and systemic symptoms like fatigue and fever. So when you are assessing joint issues and see these signs, rheumatoid arthritis should be high on your radar. Next, let us talk about gout, and this one is hard to miss once you have seen it. Gout is a type of inflammatory arthritis that is caused by the buildup of uric acid crystals in the joints. These sharp crystals trigger intense joint inflammation and pain. It is often brought on by eating a high purine diet, which includes foods like red meat, shellfish, and alcohol, especially beer. What makes gout stand out is how sudden and severe the pain is. It typically comes on overnight, is extremely intense, and most commonly strikes the big toe. The affected joint becomes red, hot, swollen, and incredibly tender. Now, picture this scenario. A middle-aged man enjoys a night out, eats steak, has a few beers, and then wakes up the next morning in excruciating pain. His big toe is red, swollen, and he cannot even tolerate the pressure of a bedsheet resting on it. That is a classic gout attack. Quick onset, extreme pain, and pinpointed inflammation, often after dietary triggers. When you see this combination in a patient, gout should be at the top of your list. Now, let us look at psoriatic arthritis. As the name suggests, this type of arthritis occurs in people who already have psoriasis, which is a chronic skin condition that causes red, scaly patches on the skin. In psoriatic arthritis, the immune system does a double attack. It targets both the skin and the joints. So if someone has a known history of psoriasis and begins to complain of joint pain, stiffness, or swelling, especially in the fingers, toes, or lower back, you should immediately think about psoriatic arthritis. Let me give you a relatable example to make this clear. Imagine a 40-year-old woman who has had red flaky patches on her elbows and scalp for years. Lately, she has started to notice stiffness and pain in her fingers, along with some swelling in her knees. That combination of skin involvement and joint inflammation is a red flag. It screams psoriatic arthritis. As a nurse, connecting the dots between skin symptoms and joint complaints is key in recognizing this condition early. Moving on to ankylosing spondylitis. This one primarily affects the spine and pelvis, and it is most common in young males. The hallmark symptom is chronic back stiffness that improves with physical activity but worsens with rest, especially first thing in the morning. What makes this condition particularly concerning is that, over time, if it is not properly managed, the inflammation can lead to the fusion of the vertebrae. That means the spine can actually stiffen and lose its natural flexibility, making it hard for the person to bend or move freely. Now, picture this case. A 25-year-old athletic man complains that his lower back feels stiff and sore every morning, but it improves after he goes to the gym or does some stretching. He has no history of injury, and the symptoms have been going on for several months. That slow onset inflammatory back pain that improves with movement and gets worse with rest is a classic clue pointing to ankylosing spondylitis. As a nurse, recognizing this early can make a huge difference in helping prevent long-term complications. And lastly, let us not forget about juvenile idiopathic arthritis. This type of arthritis affects children under the age of 16. And the tricky part is, it is not always easy to catch. Sometimes the signs are subtle. A child might just seem unusually tired, start walking with a limp, or avoid physical activity they once enjoyed. There might not even be visible swelling in the joints at first, which makes early diagnosis even more challenging. But here's the critical point. If it is not caught and treated early, juvenile idiopathic arthritis can interfere with a child's normal growth and development. Now, here's an important scenario to remember. A 9-year-old girl who used to love playing outside suddenly starts refusing to join in. Her parents notice she is limping, especially in the mornings, and she occasionally complains that her knees or wrists hurt. There is no history of any injury. This combination of morning stiffness, fatigue, and unexplained joint pain should raise a red flag for juvenile idiopathic arthritis. Early recognition and referral are essential in preventing long-term joint damage and supporting the child's overall health. Let's pause for a second. Are you ready to take the NCLEX with confidence? If not, don't worry. The complete NCLEX review course has 100 animated hours, 500 recorded hours, 5,000 high-yield practice questions, 500 NGN case studies, and 15 mock exams built to mirror the real test. You also get a 1-year ebook. Enroll now and get 70% off. Limited time offer. The link is right in the description. So here is your NCLEX takeaway. Every type of arthritis has its own unique pattern. Whether it is the age group it affects, the triggers that cause it to flare up, or the timing of its symptoms, each one has a distinct fingerprint. If you can tie the symptoms to the right patient profile, you will never get these mixed up again. Up next, we will break down the pathophysiology and what is really going on inside those joints. So stay with me. All right, nurses in training, let us go beneath the surface and talk about what is really happening inside the body with each type of arthritis. This is the part that takes you from simply memorizing facts to actually understanding what your patient is experiencing. And that, right there, is the key to clinical mastery. So let us break it down, type by type, with clear explanations of the pathophysiology, the main causes, and real-world clinical examples to help this knowledge truly stick. Let us kick things off with the first and most common type, osteoarthritis. This is the one you are most likely to encounter in older adults. And trust me, once you understand what is happening inside the joint, it makes perfect sense. Osteoarthritis is a degenerative joint disease, and it is exactly what it sounds like, a slow breakdown of the joint over time. Cartilage, which normally acts like a shock absorber between bones, gradually wears away. This leads to bone-on-bone contact, which causes pain, swelling, reduced flexibility, and even the development of bone spurs. Osteoarthritis usually develops due to aging, obesity, repeated joint stress, or previous joint injuries. Here is a clinical example to help you picture it clearly. Imagine a 60-year-old construction worker who has spent decades on his knees laying tiles. These days, he finds it harder to stand up after kneeling, and his knees start aching more as the day goes on. That is osteoarthritis in action, mechanical degeneration from years of wear and tear breaking down the joint's natural cushioning. Now let us move into something completely different from wear and tear, rheumatoid arthritis. And this one is where the immune system goes rogue. Rheumatoid arthritis flips the script. It is not mechanical, it is immune-related. The body's immune system mistakenly attacks the synovial lining of the joints, causing persistent inflammation. Over time, this chronic inflammation thickens the synovium, erodes the cartilage and bone, and eventually deforms the joint structure itself. And since it is autoimmune in nature, it does not stop at the joints. It can affect the entire body. So, what causes this? It is usually a combination of genetic predisposition, immune dysfunction, and environmental triggers such as smoking. Now, here is a clinical example to tie it all together. A 35-year-old woman comes into your clinic and tells you her hands are stiff and painful every morning. The stiffness lasts for about 2 hours, and she also mentions feeling unusually tired and running a low-grade fever. Her lab results come back with a positive rheumatoid factor. This is a textbook presentation of rheumatoid arthritis. Systemic symptoms, prolonged morning stiffness, and immune-driven joint damage. Let us move on to a type of arthritis that brings skin and joints together in a painful combination, psoriatic arthritis. This is another autoimmune condition, and it is most commonly seen in people who already have psoriasis. In psoriatic arthritis, the immune system attacks both the skin and the joints, leading to those classic scaly plaques on the skin and painful, inflamed joints underneath. It can affect the fingers, toes, spine, and even the nails. One of its signature signs is something called sausage digits, or dactylitis, where the fingers or toes become swollen and puffy. What causes it? A mix of immune system malfunction, genetic predisposition, and potential triggers like stress or infections. Now, here is a clinical example that ties it all together. A patient who already has those silvery red patches of psoriasis on their elbows now comes in complaining of stiff, swollen fingers that are tender to touch. That is psoriatic arthritis in action, an immune system double attack, targeting both the skin and the joints. When you see skin lesions paired with joint pain, always think of this diagnosis. Now, let us dive into a condition that stiffens the spine from the inside out, ankylosing spondylitis, often referred to as the spine freezer. This is a chronic inflammatory disease that primarily affects the spine and the sacroiliac joints, which are the joints connecting the lower spine to the pelvis. What happens here is that persistent inflammation slowly causes the vertebrae to fuse together over time. This leads to a rigid, hunched posture and significant chronic back pain. The hallmark feature is that it usually begins in young males, and interestingly, the pain improves with activity but worsens with rest. This is one of the key features that helps distinguish it from other types of back pain. Ankylosing spondylitis is also strongly linked to a genetic marker called the human leukocyte antigen B27, making it a condition that often runs in families. Now, here's a clinical example you need to remember. A 25-year-old athletic man tells you that his lower back hurts every morning, but the pain improves after he works out or stretches. Recently, he has also noticed it is getting harder to twist or bend his spine. This is a classic presentation of ankylosing spondylitis, chronic spinal inflammation that leads to progressive fusion of the vertebrae. Recognizing these early signs is crucial to prevent long-term spinal disability. Now, let us talk about something many people do not expect. Yes, arthritis can happen in children too. Juvenile idiopathic arthritis is an autoimmune disorder that affects children under the age of 16. It causes joint swelling, pain, and stiffness that can persist for months or even years, potentially interfering with normal growth and development. There are several subtypes of juvenile idiopathic arthritis, including oligoarticular, which affects a few joints, polyarticular, which involves many joints, and systemic, which includes symptoms like fever and even organ involvement. The exact cause is still unclear, but both immune system dysfunction and genetic factors are believed to play a role. Now, let me give you a clinical example to help you connect the dots. A 10-year-old girl has been limping for 2 weeks, and there is no history of injury. Her knee is visibly swollen, and she has been running daily fevers. That should immediately raise your suspicion for systemic juvenile idiopathic arthritis. Recognizing these signs early is critical, because untreated inflammation can lead to permanent joint damage and affect the child's overall development. Here comes your key NCLEX takeaway. And this is where everything we have covered really comes together. Osteoarthritis is all about mechanical degeneration. It is wear and tear over time. Rheumatoid arthritis and psoriatic arthritis are both autoimmune attacks, where the body turns on itself and inflames the joints. Gout is a metabolic condition caused by crystal buildup from excess uric acid. Ankylosing spondylitis is a genetic inflammatory condition that affects the spine, and juvenile idiopathic arthritis is the pediatric version of autoimmune joint inflammation. Now, here is the big clinical point you need to remember. Understanding the root cause is what truly guides the treatment. Non-steroidal anti-inflammatory drugs help with inflammation in many of these cases, but autoimmune conditions like rheumatoid arthritis and psoriatic arthritis may require disease-modifying anti-rheumatic drugs or biologics. On the other hand, gout needs medications that lower uric acid levels, like allopurinol. Being able to reason through which treatment fits which condition, that is exactly the kind of clinical thinking the NCLEX wants to see in you. One quick heads up before we begin. If you're serious about passing the NCLEX, the complete NCLEX Review online course has every resource you need: 100 animated hours, 500 in-depth lectures, 5,000 questions, 500 NGN case studies, and 15 simulated exams. You'll also get a 1-year NCLEX ebook to study anytime. Right now, get 70% off, limited time offer. Click the link below and take your first step toward passing. Now that we have cracked the code on what is happening inside the body, it is time to shift our attention to what really matters at the bedside, what your patients will actually say to you. Coming up next, we are diving into signs, symptoms, and clinical presentations. So let us turn this knowledge into practical skills you can use. All right, nurses, let us shift our focus from the textbook to real-life bedside care. You have now learned about the different types of arthritis and what is going wrong on the inside. But here is where the real NCLEX goldmine lies. What will the patient actually tell you? Because during your 7 a.m. assessment, it is not just about lab values or imaging results. It is about truly listening to what the patient is describing. These symptom patterns are what help you connect textbook knowledge to real-world clinical judgment. So let us break it down, arthritis by arthritis. With vivid, realistic examples you can picture both on the exam and in your everyday practice. Let us begin with the most common form, osteoarthritis, also known as the wear and tear pain. When you talk to patients with osteoarthritis, they will usually describe pain that gets worse the more they move and tends to improve with rest. Morning stiffness is present, but it is short-lived, typically less than 30 minutes, and it eases up once they start moving around. As a nurse, you might also observe bony enlargements in their fingers. These are called Heberden's nodes when they appear on the distal finger joints and Bouchard's nodes when they are on the proximal joints. The most commonly affected areas include the knees, hips, lower back, and hands. Here is an example to lock it in. A 72-year-old woman tells you, "My hands hurt more after gardening and my knees feel stiff when I climb stairs, but it gets better when I sit down for a while." That is classic osteoarthritis, pain and stiffness triggered by activity that improves with rest, along with those signature bony changes in the fingers. Next up is rheumatoid arthritis, which brings what we call symmetrical stiffness. And it is one of the biggest clues you can pick up during your patient assessment. With rheumatoid arthritis, you are dealing with systemic inflammation, and patients will often report morning stiffness that lasts longer than 1 hour. This stiffness typically affects both sides of the body equally, and usually starts in the smaller joints like the fingers, wrists, and toes. Since this is an autoimmune condition, you will also hear about a variety of systemic symptoms: fatigue, low-grade fevers, unintentional weight loss, and just an overall feeling of being unwell. Let us bring it to life with an example. A 35-year-old woman comes in and says, "Every morning my fingers are so stiff I cannot even twist a doorknob, and I'm just tired all the time." You also notice that her wrists are visibly swollen and the swelling is symmetrical. That is classic early-stage rheumatoid arthritis. Prolonged morning stiffness, small joint involvement, symmetrical swelling, and systemic symptoms. These patterns are exactly what help you identify the disease early and manage it effectively. Now let us talk about a condition that brings pain you will never forget. Gout, also known as the red-hot sudden pain. Gout presents with sudden, severe stabbing pain, most commonly in the big toe. The affected joint becomes red, hot, swollen, and extremely tender. So tender, in fact, that patients may tell you they cannot even tolerate the weight of a bedsheet resting on it. These attacks often come on overnight and are frequently triggered by alcohol, dehydration, or purine-rich foods like red meat and seafood. Here is a textbook example. A 50-year-old man says, "I had steak and beer last night, and I woke up at 2 a.m. with my toe feeling like it was on fire." When you assess him, his toe is red, swollen, and warm to the touch. That is a classic gout flare, sudden onset, extreme tenderness, and dietary or lifestyle triggers that set it off. Knowing these key signs can help you quickly identify and manage gout in both the clinical setting and on the NCLEX. Let us move on to a type of arthritis that does double duty: psoriatic arthritis, the classic skin joint combo. In psoriatic arthritis, joint symptoms are paired with visible skin lesions. You will want to look closely for red, scaly plaques, especially on areas like the elbows, knees, scalp, or back. One key feature that stands out is dactylitis, which refers to sausage-like swelling in the fingers or toes. It gives the digits a puffy, uniform appearance. Patients might also have nail changes, such as pitting or even separation of the nail from the nail bed. Let us bring it to life with a clear example. A 40-year-old client with a history of psoriasis says, "My fingers feel tight and puffy and my skin flares up constantly." When you assess the patient, you see swollen fingers and scaly plaques on the elbows. That is psoriatic arthritis showing both of its faces: joint inflammation and skin involvement. When you see joint pain paired with these distinct skin signs, psoriatic arthritis should be right at the top of your differential. Now let us dive into a condition that quite literally locks the spine in place: ankylosing spondylitis, the ultimate spine lockdown. This type of arthritis brings on chronic, nagging back pain and stiffness, mainly in the lower spine and sacroiliac joints. But here's the twist: it behaves differently than most types of joint pain. With ankylosing spondylitis, the pain actually gets better with movement and worse with rest. That is right. Unlike osteoarthritis, where rest is relief, here, being still makes it worse. And if left untreated, the inflammation can lead to fusion of the spine over time, forcing the person into a hunched posture with limited flexibility. Now, picture this. A 28-year-old man walks into your clinic and says, "I wake up every single morning with this dull ache in my lower back. But weirdly enough, once I get going and move around, it starts to feel better." You also notice that he is starting to lean forward when standing. That is classic ankylosing spondylitis, chronic inflammatory back pain that loosens with activity and slowly tightens the spine like a vice over time. Knowing how this stands apart from other types of arthritis will help you catch it early and manage it before long-term damage sets in. Now, let us shine a light on a type of arthritis that many do not expect: juvenile idiopathic arthritis, or what I like to call stiffness in the young. This condition affects children under the age of 16 and can show up in a variety of ways depending on the subtype. Some children may have just a few joints involved, while others may experience full-body symptoms. What makes this tricky is that kids often cannot explain their pain clearly, so it is usually the parents who pick up on subtle signs, like limping, joint swelling, or avoiding activities they once loved. In systemic cases, you might also see fevers and rashes, which can easily be mistaken for viral illnesses. Here's a powerful example to remember. A 9-year-old girl has been avoiding recess and walking with a noticeable limp. Her mother says her knee has been swollen and warm to the touch, and she has been spiking low-grade fevers daily. That should immediately raise a red flag for systemic juvenile idiopathic arthritis. When it comes to pediatrics, catching these early signs is absolutely critical to prevent long-term joint damage and support normal development. Here comes your NCLEX alert, because this is where clinical judgment really kicks in. When you are tackling arthritis-related NCLEX questions, there are 4 major symptom clues you need to focus on. First, pay attention to the timing of stiffness. Is it worse in the morning or the evening? That alone can point you toward the correct diagnosis. Second, consider whether the joint involvement is symmetrical or not. Symmetry often means autoimmune. Third, check for systemic symptoms like fatigue, fever, or weight loss. These are signs that the condition affects more than just the joints. And finally, think about what triggers the symptoms. Is it food, alcohol, periods of rest, or physical activity? These subtle but powerful differences are what will help you nail the diagnosis every single time. If you can train your brain to listen for these clues in the patient scenario, you will be ahead of the game on the NCLEX. Now that you know what your patients will say, feel, and show you, let us talk about how to confirm your suspicions. Coming up next, diagnostic tools and lab tests. We are diving into X-rays, blood work, and imaging techniques that will help you and your clinical team pinpoint the exact type of arthritis you are dealing with. Stay with me, because this next part ties everything together and is absolutely essential not only for real-life clinical decision-making, but also for your NCLEX preparation. This is where your knowledge turns into action, so let us keep going strong. Before we dive into the next topic, let me ask, are you completely prepared for the NCLEX? If there's even a bit of hesitation, our complete NCLEX review online course has your back. You'll get access to 100 hours of animated content, 500 hours of in-depth lectures, 5,000 high-yield questions, 500 NGN-style case studies, and 15 mock exams designed to feel like the real thing. You'll also receive a comprehensive NCLEX ebook, all valid for 1 full year. Right now, you can grab it at 70% off for a limited time. Thousands of students are already on the path to success, and you can be too. Click the link in the description and get started. All right, future nurses, now that we have unpacked the signs, symptoms, and what is happening inside the body with each type of arthritis, let us take it one step further. How do we actually confirm what we suspect? Because here's the truth. In clinical practice, recognizing patterns is only half the job. The other half is proving it with hard evidence. Diagnosing arthritis is like being a detective. You listen to your patient's story, pick up on subtle physical clues, and then pull out your toolkit, lab tests, x-rays, and imaging studies to solve the case. And trust me, this is the part where everything you have learned starts to click. So stay with me as we walk through the specific tests and tools used to identify each type of arthritis. We are going to match symptoms to science. And this is exactly the kind of critical thinking that will help you shine on the NCLEX and in real-world nursing. Ready? Let us break it down type by type and uncover how we put the full picture together. Let us start with osteoarthritis, also known as the mechanical breakdown. Since this is a degenerative joint condition caused by years of wear and tear, the most valuable tool for diagnosis is not a blood test. It is imaging. There is no autoimmune process or systemic inflammation going on here, so lab tests usually come back completely normal and do not offer much help. The real star in diagnosing osteoarthritis is the X-ray. When you look at an X-ray of someone with osteoarthritis, you will typically see joint space narrowing. That tells us the cartilage has worn away. You may also spot osteophytes, which are little bone spurs that form around the joint edges. In more advanced cases, you might see subchondral sclerosis, which means increased bone density just beneath the cartilage, and even some deformities if the damage has been progressing for a long time. Let us walk through an example. A 70-year-old woman comes to the clinic complaining of knee pain that gets worse as the day goes on. Her blood work looks totally normal, but her X-ray shows narrowing in the knee joint and a few small bone spurs. That is a classic case of osteoarthritis confirmed through imaging. And here is a quick NCLEX tip. If you see a question where the lab results are normal, but the X-ray shows joint changes like narrowing or bone spurs, always think osteoarthritis. That clue will help you eliminate the wrong answers fast. Now, let us dive into rheumatoid arthritis, the immune system misfire that you definitely need to recognize for both real-life practice and the NCLEX. Unlike osteoarthritis, which is caused by years of wear and tear, rheumatoid arthritis is an autoimmune condition. That means the body's own immune system is mistakenly attacking the joints, leading to chronic inflammation that is not just limited to the joints, it is systemic. And because of that, both blood tests and imaging are essential when it comes to confirming the diagnosis. So let us break it down clearly. For lab work, we usually start by checking for something called the rheumatoid factor. It is positive in about 70 to 80% of people with rheumatoid arthritis. But here is the thing, it is not always enough on its own. A more specific test is the anti-cyclic citrullonated peptide antibody, which can pick up the disease even in its early stages. We also look at inflammatory markers like erythrocyte sedimentation rate and C-reactive protein, which tend to be elevated when there is active inflammation in the body. Now let us talk about imaging. Tools like X-rays or magnetic resonance imaging are super helpful because they can show joint space narrowing, bone erosions, and even reduced bone density near the affected joints. And yes, you can see these changes even early in the disease. Let me give you a realistic example. Imagine a 32-year-old woman who walks into your clinic. She tells you her wrists are swollen, her fingers are stiff for over an hour every morning, and she is just exhausted all the time. Her lab results show a positive rheumatoid factor and an erythrocyte sedimentation rate of 65 millimeters per hour. That combination of joint symptoms, systemic complaints, and lab findings is textbook rheumatoid arthritis. And here is your NCLEX tip. If the case includes symmetrical joint pain, prolonged morning stiffness, fatigue, and those elevated inflammatory markers, rheumatoid arthritis should be your top pick. This is where your clinical reasoning really matters, and knowing how to connect all these pieces is exactly what sets you apart as a confident, competent nurse. Now, let us turn our attention to gout, the crystal crisis that brings on sudden, intense pain and swelling. Gout is a type of inflammatory arthritis that happens when uric acid builds up in the blood and forms sharp crystals inside the joints. To confirm a diagnosis of gout, we use both blood tests and, more definitively, joint fluid analysis. First, we check the serum uric acid level, which is often elevated in people with gout. But here's the important part. During an acute flare, the uric acid level can actually be normal. So you cannot rely on this test alone to make your diagnosis. A complete blood count might also show elevated white blood cell levels during a flare, simply due to the inflammation. Now, let us talk about the gold standard. The most definitive test for gout is joint aspiration. This is when fluid is drawn directly from the affected joint and looked at under a microscope. If gout is present, the synovial fluid will show needle-shaped monosodium urate crystals, and under polarized light, they will have strong negative birefringence. That is the hallmark finding for gout. Let me walk you through a real-world scenario. A 50-year-old man comes into the emergency room with excruciating pain and swelling in his big toe. He tells you he had seafood and alcohol over the weekend. His uric acid level is mildly elevated, but the real answer comes from the joint fluid analysis, which clearly shows those urate crystals. That is your confirmed case of gout. And here is your NCLEX tip. Always remember, the most definitive way to diagnose gout is not just by looking at the uric acid level, but by analyzing the synovial fluid. That is what confirms the diagnosis with certainty. Now let us dive into psoriatic arthritis, the skin joint link that ties together dermatology and rheumatology in a powerful way. Psoriatic arthritis is usually diagnosed clinically, but lab tests and imaging studies are essential in helping us confirm and distinguish it from other forms of arthritis. What makes psoriatic arthritis unique is that it typically occurs in people who already have psoriasis, a chronic skin condition that causes red, scaly patches, especially on the elbows, knees, scalp, or back. When it comes to lab work, one of the biggest clues is what you do not find. Rheumatoid factor and anticyclic citrullinated peptide antibodies are usually negative, and that helps us rule out rheumatoid arthritis. However, inflammatory markers like erythrocyte sedimentation rate and C-reactive protein may be elevated, especially when the disease is active. On imaging, we may see joint space narrowing and erosions, often in an asymmetric pattern. One distinctive finding you will want to remember for both the NCLEX and your clinical practice is the pencil and cup deformity. This is where the ends of the bones appear sharpened and eroded, resembling a pencil sitting inside a cup, a telltale radiographic sign of psoriatic arthritis. Now, picture this scenario. A 40-year-old patient who has had psoriasis for several years now comes in complaining of swollen fingers and joint pain. Their lab results are negative for rheumatoid arthritis markers, but the X-ray shows a clear pencil and cup deformity. That right there is a textbook case of psoriatic arthritis. When you see joint pain in a patient with a history of psoriasis and those classic imaging signs, psoriatic arthritis should be high on your differential list. All right, let us talk about a condition that quite literally locks up the spine: ankylosing spondylitis, the spinal signature you absolutely need to recognize. Now, imagine this. A young adult walks into your clinic and says, "Every morning, my lower back feels so stiff I can barely move. But after I start walking around, it gets better." That right there is your first major clue. Ankylosing spondylitis primarily affects the spine and the sacroiliac joints. And when it comes to diagnosis, we lean heavily on two big tools: imaging and genetic testing. So here is how you connect the dots. First, from a lab perspective, we test for the human leukocyte antigen B27 gene. This test is positive in about 90% of affected white males, making it a huge red flag. You may also see elevated inflammatory markers like erythrocyte sedimentation rate and C-reactive protein. When the disease is active, but do not let normal values fool you, they are not always reliable. Now, let us get to the imaging. This is where things get visual and real. X-rays or magnetic resonance. Imaging can reveal inflammation in the sacroiliac joints, especially early in the disease. But as the condition progresses, something really striking can appear: what is called a bamboo spine. This is when the vertebrae actually begin to fuse together, giving the spine a stiff, rod-like look that resembles, you guessed it, a bamboo stalk. Now picture this full case. A 28-year-old man reports that his lower back pain is worst in the morning, but improves with movement. His human leukocyte antigen B27 is positive, and his imaging shows early sacroiliac inflammation. That is classic ankylosing spondylitis. So for NCLEX success and real-world nursing, remember, this is one arthritis that loves the spine, hates inactivity, and shows up early with stiffness that disappears with motion. Stay alert to these patterns, because early recognition can prevent lifelong complications. Let us bring it all together with a high-yield NCLEX summary, because this is where all the key points finally lock in. When it comes to osteoarthritis, remember that X-rays are your most valuable tool. They help you identify structural joint changes such as joint space narrowing, bone spurs, and subchondral sclerosis. For rheumatoid arthritis, focus on rheumatoid factor, anticyclic citrullinated peptide antibodies, and inflammatory markers like erythrocyte sedimentation rate and C-reactive protein. These help confirm autoimmune inflammation. For gout, never rely on uric acid levels alone. The gold standard is joint aspiration and crystal analysis, where you specifically look for needle-shaped monosodium urate crystals with strong negative birefringence under polarized light. For psoriatic arthritis, think skin and joints together. You will want to perform a skin assessment, look for rheumatoid factor negative lab results, and confirm findings on imaging, especially if you see the classic pencil and cup deformity. For ankylosing spondylitis, count on human leukocyte antigen B27 genetic testing and spinal imaging to detect early sacroiliac inflammation and later-stage bamboo spine. Finally, for juvenile idiopathic arthritis, focus on anti-nuclear antibody, erythrocyte sedimentation rate, rheumatoid factor, and patient history. especially if the child is experiencing systemic symptoms like a salmon pink rash or recurring fevers. These are the exact clues you need to pick up on the NCLEX. And now, you are well prepared to spot them every time. You are doing amazing so far. Now that we have covered how to diagnose each type of arthritis, it is time to move on to the most important part of nursing care, management and treatment. This is where your role as a nurse really shines. What medications do we give? What non-pharmacologic interventions can truly make a difference? And how do we support these patients not just during a flare-up, but over time as they learn to manage a chronic condition? Stick with me, because the next section is packed with high-yield information that is absolutely crucial, not just for passing the NCLEX, but for giving your future patients the best possible care every step of the way. Let's take a quick moment before we begin. Are you confident about passing the NCLEX? If not, don't worry. The complete NCLEX Review online course gives you 100 hours of animations, 500 hours of recorded lectures, 5,000 practice questions, 500 NGN-style case studies, and 15 mock exams just like the real test. You'll also get an ebook and 1 year of full access. Enroll now and get 70% off, only for a short time. Head to the link in the description and start your success journey. All right, future nurses, this is where your clinical skills, critical thinking, and patient advocacy truly come into play. Managing arthritis is not just about handing out medications. It is about relieving pain, preserving mobility, preventing long-term complications, and helping patients live functional, fulfilling lives. And here is where your role becomes essential. Every type of arthritis has its own unique treatment plan based on what is causing it, how severe the symptoms are, and what the patient's day-to-day life looks like. Some conditions call for immunosuppressants, others need lifestyle adjustments, and many require both. So let us take it one step at a time. We are going to go through each type of arthritis individually, and I will walk you through the most important nursing interventions for each one. I will also give you real-life examples to help make the concepts stick, not just for your NCLEX, but for the moment you step onto the floor as a practicing nurse. Let us get into it. Let us begin with osteoarthritis, also known as the wear and tear warrior. In this condition, the main goal of management is to reduce joint pain, slow down further joint degeneration, and improve the patient's mobility and overall function. Since osteoarthritis is mechanical in nature, not inflammatory or autoimmune, our focus as nurses is centered around anti-inflammatory strategies and lifestyle modifications that protect the joints. One of the first things you want to assess is the patient's weight. If they are overweight, encouraging weight loss is a top priority because excess body weight increases the pressure on weight-bearing joints like the knees and hips, which only worsens the pain. Now, let us talk about activity. You should always promote low-impact exercises such as walking, swimming, or water aerobics. These types of movement help maintain joint function without causing extra strain. Recommending physical therapy is also key. It helps strengthen the muscles that support those overworked joints. Now, let us go over medications. Pain management for osteoarthritis often starts with acetaminophen because it is gentle on the stomach. If that is not effective, non-steroidal anti-inflammatory drugs may be introduced. But as a nurse, you need to keep an eye out for possible side effects like gastrointestinal irritation or kidney complications. Heat therapy is another great tool for easing morning stiffness, while cold packs can be helpful during flare-ups to reduce inflammation and swelling. Here is a great example to bring this to life. A 72-year-old woman tells you that her hands ache after gardening and her knees feel stiff after climbing stairs. In this situation, you would educate her on alternating periods of activity and rest, recommend warm compresses in the morning to help loosen up the joints, and possibly suggest a referral for physical therapy. You might also guide her on how to safely use assistive devices at home, like grab bars or a cane, to protect her joints and keep her independent. This is how we help patients with osteoarthritis not only manage their pain, but maintain their quality of life. Now let us tackle rheumatoid arthritis, the autoimmune challenger that calls for early, aggressive intervention. Since this condition is fueled by an overactive immune system, the top priority is to suppress that response and calm systemic inflammation. Patients are often started on disease-modifying anti-rheumatic drugs like methotrexate, which help slow joint damage but require close monitoring for bone marrow suppression, liver toxicity, and infection risk. In more advanced cases, biologic agents like adalimumab or etanercept may be added. During flare-ups, short-term corticosteroids or non-steroidal anti-inflammatory drugs can offer quick relief. As a nurse, you should encourage low-impact exercise to keep joints flexible and recommend occupational therapy to teach joint protection strategies. Now, picture this scenario. A 40-year-old woman newly diagnosed with rheumatoid arthritis begins methotrexate. You would teach her to take folic acid to ease side effects, stress the importance of reporting infections early, and make sure she comes in regularly for liver function tests. This is where nursing care goes beyond medication. It is about education, prevention, and empowering your patient every step of the way. Now let us break down gout, the crystal crisis that hits hard and fast. Managing gout comes down to two key goals: treating the current flare and preventing the next one by controlling uric acid levels. During an acute attack, you will give non-steroidal anti-inflammatory drugs or colchicine to reduce inflammation, but avoid aspirin since it can actually make things worse by increasing uric acid retention. Cold packs help reduce swelling, and the patient should rest the affected joint completely. For long-term management, medications like allopurinol or febuxostat are used to lower uric acid levels. But medication alone is not enough. Patient education is essential. Teach them to steer clear of purine-rich foods like red meat, organ meats, shellfish, and especially alcohol and beer. Encourage hydration, which helps flush out uric acid, and always monitor kidney function during treatment. Here is a classic scenario. A patient shows up with a red, swollen big toe after a weekend of steak and beer. You treat the pain with colchicine, and then start your education, talking about diet changes, the importance of drinking water, and why they must take allopurinol every day, even when they feel completely fine. That is how you tackle gout, from crisis to control. Now here is where things get a little more complex, because when skin and joints collide, we are talking about psoriatic arthritis. This autoimmune condition demands a dual-focus approach that treats both joint inflammation and the chronic skin issues that come with psoriasis. For patients with mild joint symptoms, non-steroidal anti-inflammatory drugs may be enough to provide relief. But in more advanced cases, disease-modifying anti-rheumatic drugs like methotrexate or biologic agents such as secukinumab are prescribed to suppress the immune response and control disease progression. As a nurse, you may also play a role in managing the skin side of things, applying or teaching about topical treatments like corticosteroid creams or vitamin D analogs for those scaly plaques. Patient teaching is essential. You should educate them on maintaining proper skin hydration with gentle moisturizers and avoiding known irritants that can trigger flare-ups. If nail involvement is present, suggest keeping nails short and clean to reduce pain and minimize further damage. Now imagine this clinical scenario. A patient walks in complaining of swollen, painful fingers and red scaly patches on their elbows. You coordinate care with both dermatology and rheumatology, assist with medication management, and guide the patient on how to care for both their joints and skin. This is where your ability to think holistically makes all the difference. Let's kick things off with a classic presentation question that tests your ability to recognize the subtle yet important clues of osteoarthritis. Question number 1. A nurse is assessing a 68-year-old client who reports joint pain and stiffness. The client says, "My knees ache more at night after walking all day, and they feel really stiff when I first sit down, but loosen up after a few minutes." Based on this information, which condition is most consistent with the client's symptoms? Here are your option choices. A. Rheumatoid arthritis. B. Gout. C. Osteoarthritis. D. Systemic lupus erythematosus. The correct answer is C. Osteoarthritis. Let's see the rationale. The symptoms described: pain that worsens with activity and improves with rest, joint stiffness after inactivity, and involvement of weight-bearing joints like the knees are hallmark features of osteoarthritis. It typically affects older adults and involves mechanical wear and tear of cartilage. The client's description of worsening pain as the day progresses and stiffness after sitting are textbook signs. Let's see why other options are incorrect option. A rheumatoid arthritis pain is typically worse in the morning and improves with activity. It also usually presents with prolonged stiffness lasting more than 30 minutes upon waking and tends to affect smaller joints symmetrically, like the hands and wrists. Option B. Gout presents as sudden, severe pain with redness and swelling, often in the big toe. It does not follow a pattern of worsening with use throughout the day. It's characterized by acute attacks. not chronic stiffness after movement. Option D. While lupus can involve joint pain, it is systemic and usually includes skin, renal, or neurologic involvement. It is more common in younger women and does not typically follow the osteoarthritis pain pattern described in the scenario. Now let's switch gears to a rapid onset condition with a crystal clear presentation. Gout. Question number 2. A 52-year-old man arrives at the emergency department complaining of sudden severe pain in his right big toe that began overnight. He states, "It feels like my toe is on fire. I could not even let the bedsheet touch it." He admits to having steak and beer at dinner the night before. On examination, the toe is red, swollen, and warm to the touch. Which condition does the nurse most suspect based on these findings? Here are your option choices. A. Osteoarthritis. B. Rheumatoid arthritis. C. Gout. D. Cellulitis. The correct answer is C. Gout. Let's see what the option C is correct. The patient's symptoms and history are classic for gout. Sudden onset of intense pain in the big toe, first metatarsophalangeal joint, swelling, redness, and extreme tenderness, especially after a purine-rich meal, steak and beer. The pain is often so intense that even light contact, like a bedsheet, becomes unbearable. These attacks typically occur at night and peak quickly. Let's see why other options are incorrect. Option A. Osteoarthritis pain is chronic and develops gradually. It is typically worse after activity and affects weight-bearing joints like the knees or hips. It does not present with sudden, intense pain and inflammation in the toe. Option B. Rheumatoid arthritis involves chronic, symmetrical joint pain that is worse in the morning and improves with activity. It does not cause sudden, isolated, intensely painful joint flares like this. Option D. While cellulitis can cause redness and swelling, it is usually associated with infection of the skin and soft tissue rather than a joint. It does not have the sudden, overnight onset or the dietary triggers seen in gout. Coming up next, here's a question that highlights clinical presentation with rheumatoid arthritis. Question number 3. A nurse is assessing 3 clients with joint complaints. Which client's presentation is most consistent with rheumatoid arthritis? Here are your option choices. A. A 68-year-old retired athlete with chronic knee pain that worsens after physical activity. B. A 74-year-old woman who struggles to open jars due to finger pain and weak grip strength. C. A 30-year-old woman who reports morning stiffness and swollen fingers that improve after an hour. D. A 65-year-old man who experiences sharp big toe pain after eating red meat and drinking beer. The correct answer is C. A 30-year-old woman who reports morning stiffness and swollen fingers that improve after an hour. Let's see the rationale. This client exhibits classic signs of rheumatoid arthritis. Early onset, typically between ages 30 and 50. Morning stiffness lasting more than 1 hour. And bilateral joint inflammation, especially in the small joints of the hands. These are hallmark features of autoimmune arthritis. Let's see why other options are incorrect. Option A. This client fits the profile for osteoarthritis, especially given the history of joint overuse from sports. Pain that worsens with activity and improves with rest is a telltale sign of wear and tear arthritis. Option B. Difficulty opening jars and finger joint pain suggests functional impairment, which can occur in both types of arthritis, especially in late stages. However, this presentation lacks specificity and does not clearly point to rheumatoid arthritis. Option D. This is a textbook case of gout, not rheumatoid arthritis. Sudden toe pain after consuming purine-rich foods like red meat and alcohol is characteristic of acute gouty arthritis. Coming up next, here's a question that highlights the everyday lifestyle changes nurses can recommend to help clients manage osteoarthritis effectively. Question number 4. A 72-year-old woman with osteoarthritis of the knees and hands reports that her joints ache after gardening and feel stiff after using the stairs. Which nursing intervention is most appropriate to include in the plan of care? Here are your option choices. A. Recommend high-impact exercises to improve joint flexibility. B. Suggest using warm compresses for stiffness and assistive devices for safety. C. Instruct the client to take high-dose, non-steroidal anti-inflammatory drugs daily. D. Encourage complete joint rest to prevent further degeneration. The correct answer is B. Suggest using warm compresses for stiffness and assistive devices for safety. Let's see why the option B is correct. This aligns with evidence-based osteoarthritis management. Warm compresses relieve morning stiffness. and assistive devices like grab bars or canes help reduce joint stress and enhance safety. Nursing care focuses on symptom relief, preserving mobility, and slowing wear and tear. Let's see why other options are incorrect. Option A, high-impact activities such as running or jumping can worsen joint wear and osteoarthritis. Low-impact exercises like walking, swimming, or water aerobics are safer and more effective for maintaining mobility. Option C, while non-steroidal anti-inflammatory drugs are sometimes used, they are not the first-line treatment due to gastrointestinal and renal side effects, especially in older adults. Acetaminophen is typically recommended first for mild to moderate pain. Option D, prolonged inactivity can lead to stiffness and muscle weakness. The key is to balance activity and rest to maintain function without overstraining the joints. Now let's move into pharmacology, where rheumatoid arthritis meets its frontline medication, methotrexate. Question number 5. A 60-year-old client newly diagnosed with rheumatoid arthritis is prescribed methotrexate. Which nursing instruction is the highest priority during the initial phase of treatment? Here are your option choices. A. Encourage the client to begin high-impact exercise to maintain bone density. B. Instruct the client to monitor for signs of liver dysfunction and infection. C. Recommend stopping the medication if joint pain persists for more than 2 weeks. D. Advise the client to reduce protein intake to minimize kidney stress. The correct answer is B. Instruct the client to monitor for signs of liver dysfunction and infection. Let's see why the option B is correct. B. Methotrexate is a disease-modifying anti-rheumatic drug, DMRD, that suppresses the immune system to slow joint destruction. However, it carries serious risks including liver toxicity, bone marrow suppression, and increased infection risk. Clients must be educated to report signs like fever, fatigue, jaundice, or unusual bleeding. Routine blood work is necessary to monitor liver enzymes and blood cell counts. Let's see why other options are incorrect. Option A. High-impact exercises can worsen joint damage. Clients with rheumatoid arthritis benefit more from low-impact activities like walking or swimming, which preserve joint function without aggravating inflammation. Option C. Methotrexate takes several weeks to start working. Pain may persist initially, and stopping the medication without provider direction can disrupt the treatment plan and lead to uncontrolled disease progression. Option D. There is no need to reduce protein for methotrexate use unless the client has another condition, like kidney disease. In fact, maintaining adequate nutrition is important for healing and immune function. Let's continue with gout, but now we'll shift focus to long-term management. How do we prevent future flare-ups? Question number 6. A client with a history of recurrent gout attacks is prescribed allopurinol. Which instruction should the nurse include in the client's teaching plan? Here are your option choices. A. Take the medication during acute gout flares for rapid relief. B. Avoid drinking excess fluids to prevent joint swelling. C. Monitor for signs of kidney dysfunction and avoid purine-rich foods. D. Use aspirin for joint pain instead of non-steroidal anti-inflammatory drugs. The correct answer is C. Monitor for signs of kidney dysfunction and avoid purine-rich foods. Here's the rationale for option C. Allopurinol is used for long-term control of gout by lowering uric acid levels. It is not meant for acute flare relief. Clients must avoid purine-rich foods, like red meat, organ meats, and shellfish, which increase uric acid. Because allopurinol is cleared through the kidneys, monitoring renal function and maintaining adequate hydration are essential to prevent complications. Let's see why other options are incorrect. Option A. Allopurinol should not be initiated during an acute gout attack, as it can actually worsen or prolong the flare when started during active inflammation. It is strictly for preventive, long-term use. Option B. Hydration is actually encouraged to help flush out uric acid through the kidneys. Limiting fluids can worsen uric acid crystal accumulation and kidney stone formation. Option D. Aspirin should be avoided in gout, as it can affect uric acid levels and may exacerbate the condition. Non-steroidal anti-inflammatory drugs like indomethacin or colchicine are preferred for acute attacks. Let's test your nursing care response skills now with ankylosing spondylitis. Question number 7. A 28-year-old client diagnosed with ankylosing spondylitis reports chronic lower back pain and morning stiffness that improves with activity. Which nursing intervention is most appropriate to include in the care plan? Here are your option choices. A. Encourage prolonged bed rest to reduce spinal strain. B. Recommend the use of soft mattresses and heated blankets. C. Promote daily stretching and deep breathing exercises. D. Instruct the client to limit physical activity to avoid flare-ups. The correct answer is C. Promote daily stretching and deep breathing exercises. Let's see why the option C is correct. Ankylosing spondylitis is a chronic inflammatory disease that can lead to fusion of the spine and restricted chest expansion over time. Daily posture-focused stretching helps maintain spinal mobility, and deep breathing exercises preserve lung expansion and prevent restrictive lung complications. These are key nursing interventions to slow disease progression and improve quality of life. Let's see why other options are incorrect. Option A, bed rest can actually worsen stiffness and accelerate spinal fusion. Regular physical activity is necessary to maintain mobility. Option B, soft mattresses may worsen spinal alignment. A firm mattress is generally better for maintaining posture and reducing pain. Option D, limiting activity promotes stiffness and immobility, which is exactly what we want to prevent in ankylosing spondylitis. Clients should engage in low-impact exercises like swimming or yoga. Let's test your priority intervention response skills, now with a high-risk arthritis complication, septic arthritis. Question number 8. A 70-year-old client with a history of diabetes presents with acute onset joint pain, swelling, redness, and fever. Septic arthritis is suspected. Which action should the nurse anticipate as the priority intervention? Here are your option choices. A. Apply heat to the affected joint to relieve discomfort. B. Administer oral non-steroidal anti-inflammatory drugs and monitor response. C. Prepare the client for joint aspiration and intravenous antibiotic therapy. D. Encourage early ambulation to prevent joint stiffness. The correct answer is C. Prepare the client for joint aspiration and intravenous antibiotic therapy. Here's the rationale that why option C is correct. Septic arthritis is a medical emergency. The priority is to obtain synovial fluid through joint aspiration for culture and analysis, which confirms the diagnosis and guides targeted antibiotic treatment. Intravenous antibiotics should be started immediately after cultures are obtained to prevent joint destruction and sepsis. Let's see why other options are incorrect. Option A. Heat should be avoided in septic arthritis, as it may worsen inflammation or accelerate bacterial spread. Cold packs may be used cautiously for pain relief once treatment is initiated. Option B. Non-steroidal anti-inflammatory drugs may relieve pain, but they do not address the underlying infection. Septic arthritis requires parenteral antibiotics and often surgical drainage. Option D. During the acute phase of septic arthritis, the affected joint should be immobilized initially to reduce pain and inflammation. Weight bearing is typically deferred until infection is controlled. Let's continue with a fundamental nursing question that goes beyond medications, supporting clients through lifestyle and functional care. Question number 9. A nurse is teaching a client with chronic arthritis about non-pharmacological strategies to reduce pain and maintain joint function. Which client statement indicates a correct understanding of the teaching? A. I should avoid all physical activity to protect my joints from further damage. B. Using a heating pad in the morning can help reduce my joint stiffness. C. I will only exercise when I am completely pain-free. D. Cold packs should be used regularly, even if I do not have swelling. The correct answer is B. Using a heating pad in the morning can help reduce my joint stiffness. Let's see why the option B is correct. Heat therapy helps improve circulation, reduce muscle tension, and ease morning stiffness, especially useful in both rheumatoid and osteoarthritis. This is an effective and commonly recommended non-drug strategy. Let's see why other options are incorrect. Option A. Total inactivity can worsen joint stiffness and muscle weakness. Instead, clients should be encouraged to engage in low-impact exercise like walking, swimming, or water aerobics to preserve joint function and strength. Option C. Incorrect. Waiting for complete absence of pain may lead to deconditioning. Clients should be educated that gentle activity is beneficial even with mild discomfort, unless there is acute inflammation or flare. Option D. Cold therapy is most effective during acute flares or swelling. Using it without symptoms may not provide benefit and could cause unnecessary discomfort. And finally, let's wrap up with nutrition-based question that tests how well you understand dietary triggers and gout management. Question number 10. A nurse is providing dietary teaching to a client with a history of recurrent gout attacks. Which statement by the client indicates a need for further teaching? Here are your option choices. A. I will limit my intake of red meat and shellfish. B. I should avoid drinking beer, even on special occasions. C. I will increase my water intake to help flush out uric acid. D. I can enjoy liver occasionally since it is high in protein. The correct answer is D. I can enjoy liver occasionally since it is high in protein. Here is the rationale that why option D is correct. This is the incorrect statement. Liver is one of the highest purine-containing foods, which break down into uric acid and trigger gout flares. Even occasional consumption can provoke an attack and should be strictly avoided. Let's see why other options are incorrect for this question. Option A. This reflects appropriate gout dietary management. Red meats and shellfish are known gout triggers due to their purine content. Option B. States that alcohol, especially beer, increases uric acid production and decreases its excretion. Avoiding beer is a smart and necessary adjustment. Option C. Hydration is crucial in gout management. It helps dilute and excrete uric acid through the kidneys, reducing crystal formation.